Is Dr. Basu here? After that, Dr. Dilip Lalwani is here. Dr. Srushti Raj is here. The third presenter, Dr. Srushti Raj is here. So you will be presenting third, ma'am?
Yes, it's a fourth.
Yeah, that is what, because Srushti is not there. So you will be presenting third.
A very good morning to every one of you. Thank you AOC for giving me this opportunity to present here. So I'll be speaking on use of Octa or OCT angio in glaucoma. So what is Octa? It's a non-invasive imaging procedure. It has a scan acquisition time of 5 to 6 seconds, and it has a high repeatability, high reproducibility, and it is dye-free. These are the Octa machines. All the companies have their own version of Octa. Zeiss have Angioplex, Optoview have AngioView, Topcon have Maestro 2, Heidelberg have their own OCT angio module. So how they actually image the how Octa works? Octa uses a low coherence laser light reflectance, and it actually images the blood cells, moving blood cells in the vessels. That's how it depicts the blood vessels in the retina. So what it does, they take fast axial scans in the same location, and then slowly they take images in the same location. So that gives a on-fast image like the in the left side. What all datas the Octa gives? They give the vascular density in and around the optic nerve and the flow index of the optic nerve, the vascular density in the peripapillary retina, and the vascular density in the macula. So the main significance in the glaucoma is the blood flow, the capillary diameter, and papillary vessel, the vascular density around the optic nerve. How they give this data? These are all play of the softwares. All the machines have their own softwares, be it SSADA, which is known as split spectrum amplitude decorrelation angiography, which is there in AngioView, or OMAG, the OCT based microangiography. It's in Zeiss Angioplex, or OCT ratio analysis, which is there in Topcon. So the spectral domain OCT, along with this softwares, they give this different values, the flow index and the vascular density. There are mainly two slabs of Octa. One is the RPC slab, or the superficial slab, and one is the choroidal slab, or the deeper slab. We are more focused on the superficial slab for the glaucoma analysis. This is a picture of angioplex. It gives a p-value and the flux index. The p-value is the vascular density in each quadrant. So this is a healthy disc, and there is a marked reduction in the left side in the glaucomatous disc. The two main entity which they give is one flow index, and another is vascular density. Flow index we generally don't use much in glaucoma because the reproducibility is poor, and there is changes in the physiological state or stress also. If one person goes for a running and comes back and then take a OCT angio, the flow index will be much more increased. So the variability is much more higher. The vascular density is much more specific for glaucoma. It's a percentage of area occupied by the vascular pixels in the on-fast angiogram. The reproducibility is better, and it is used for the diagnosis and monitoring. There are lots of studies published in OCT angiography since 2014 or 15. I'll go through some of the studies, how it is giving idea about the glaucoma. So this study by Wang et al., it has shown from normal to severe glaucoma, it has a significant decrease in vascular density along the disease progression. If there is any correlation between the visual field and OCT angiography, this paper by Yar Mohammadi et al. Has shown that it actually corresponds with the visual field defect. The more severe the glaucoma, the less number of the vascular density reduces. Whether there is any correlation with the OCT also. This paper by Gaiman et al. Has shown that OCT angio and OCT pictures and our visual field, they walk hand in hand, and the OCT angiography, the severe vascular density loss is corresponded with the RNFL thickness loss and marked visual field defect. Whether it has any role in pre-perimetric glaucoma, we are more interested in the pre-perimetric glaucoma with these imaging modalities. This paper by Kenemau et al. Have shown that in a 61-year-old patient where the disc is around 0.7 IR less than SR, in that case, the HVF is absolutely normal, but the OCT angio is picking up, the vascular density has come down. In the OCT angiography, the pedipapillary, the OCT, the ONH is taken 4 into 5 box, but in macula it is taken in the 6 into 6 box because the damage is in the peripheral retina, the RNFL. That's why the macular program is always 6 into 6 cube. This study by Mohogimi have shown that macular and ONH vessel density both have relation with the advancement of glaucoma. This study also by Shoji et al. Has shown that macular vessel density also has a low role in diagnosing the primary open angle glaucoma. This is the first one to pick up the loss of reduced vascular density. This study by Choi et al. Has shown with each clock hour measurement in pedipalpable RNFL thickness, there is a significant decrease from the normal population as well as in the macular GCPIL also, and everything is p-value less than 0.001, which is pretty significant. So the glaucoma can be diagnosed with early glaucoma can be diagnosed with the OCT angio module. This study, we have spoken about the superficial vessels, but there is a role in deeper vessel architecture also. In the choroidal microvascular dropout shows if there is a dropout in choroidal microvasculature, there is a rapid central visual field progression. This study is shown by Zhou et al. Some persons are actually not very comfortable with doing with HFA or automated perimetry. In those cases, what we can do is through the Octa, it can give an overlay of the HVF progression and which gives a AI module HVF of that patient, and we can use it for glaucoma progression also. There is no model for glaucoma progression through to notice glaucoma progression in Octa. That's a limitation for Octa users, and it actually measures the volume, velocity of the RBC cells. So there are so many of artifacts. There are line artifacts in there. That is a limitation for Octa, and there is always a chicken and egg theory. Whether the structural damage is first or the vascular loss is first, that's a debatable question. So that is the limitation for Octa. Thank you.
Thank you, Basu, for nice presentation on Octa. So how do you place an Octa or over the OCT? Like there are certain places where you can place it above OCT.
Yeah. In certain situations like where the vascular factor comes into my mind, like NTG or some glaucoma where it is progressing even with controlled IOP, in target IOP, in those cases we can place Octa, but always there is a debate about that chicken and egg theory, which comes first, whether the structural damage comes first or the vascular dropout comes first. That is a debatable question. So still more study is required. We have to gather the information more, so we have to do more Octa to come to definite conclusion.
Thank you. Panelists want to comment anything on this?
Currently, the role plays in detection of early glaucoma. Probably that is where I think Octa stands now. So definitely, because now more and more early detection is given more importance. So before the functional damage starts, the Octa is showing that it can pick up an early damage. So I will put it in that category wherein we need to
So
detect for
that for
more
that
often.
we have been already using an OCT. That is what
Yeah.
I'm
So
asking. That in
even
early glaucoma, if we are using OCT as it is, then what is the role of Octa? That's what I asked.
so that's what I said. Even like Octa is also placing role. Probably there are some parameters which can be picked up in Octa in compared when compared to OCT much earlier.
So that means we can detect glaucoma even earlier than
Then
OCT
yeah,
changes.
yeah.
But
That
then, do
is,
we
but
treat
still,
that patients? That
yeah,
also is a
that is
question.
also a
Yeah.
question. Yes.
Thank you, Dr. Basu. Now we come to our second presentation. Watch the SC angle by Dr. Dilip Lalwani.
Good morning, all. And outset, I would like to thank our Holiday Society and Scientific Committee for this opportunity. My talk is on why thigh angle and anti-chamber. So, why angle and anti-chamber is so important? Because although open angle glaucoma population of open angle glaucoma is much more than angle closer glaucoma, but ratio of blindness is 1:1. Primary angle closer glaucoma carries threefold risk of severe blindness rather than open angle glaucoma. So, which type of glaucoma related with the angles? Lot of like primary angle closure, neovascular, lens induced, traumatic, pigmentary. We have to do how to watch this our angle. So subjective method, objective method. First focus about the subjective method, that is von Herrick and gonioscopy. So this is a von Herrick test. Limbal chamber depth as a fraction of corneal thickness. It is a semi-quantitative test, gives suboptimal result, hardly reproducible. Second one is a gonioscopy, that is the indirect one. It is the most common, and gonioscopy will tell about all angle grading to iris configuration, deposits of synechiae or pigments, vessels, and it is the most critical instrument, and you can tell that it is an open angle or closed angle. It is tell that why this is a complete angle closure, not it is an open angle, because of corneal wedge. You can tell about with the gonioscopy the strab ostium is patent or not, thick anteriorly placed lens, or any regular arborization of vessels crossing scleral spur, it is a new vessels or not, pigment dispersion syndrome. With the gonioscopy, you can do dynamic assessment and will have a better understanding of pathology, and you can observe likely effect of PI or any procedure. But gonioscopy has many limitations like observer dependent, lighting, 2-3 type lenses. Documentation is a very big limitation, skill and expertise. This limitation will overcome by UBM. It will give a high resolution of 50 micron, and it is independent of corneal opacity, and dynamic changes can be recorded. And this is the UBM scan orientation. So UBM has a role in glaucoma. It can image iris ciliary complex. It can refine our concept and modify our therapy in like this aqueous misdirection syndrome. In plateau iris, you can see there is an anteriorly directed ciliary process. Then you can confirm plateau iris. In this case, lens-induced angle closure, you can see the phacomorphic lens clearly visible by this method, but has a limitation. Angles open up supine position, only one quadrant imaging, need a skilled examiner, and it cannot detect pigmentation, neovascularization, and inflammatory exudates. Next comes the ASOCT. Its interpretation depends location of scleral spur and curvature change appear as an invert protruding sclera. So, but it will give 45% false positive. We still need do a gonioscopy. So, advantage of ASOCT is a high resolution, non-contact method, all 4 quadrants at same time, sitting position, entire cross section in one frame, ancillary body not imaged fully. This is the limitation. Eyelid obstruction. So both had a similar, but ASOCT has a ease of operation, sitting position, no distraction of globe. Newer imagings are coming like this CASIA SSOCT. It can clearly tell about the close angle iridotrabecular contact index. And right one is the HD OCT, clearly visible Schwab's line. So here is we can conclude here, expensive technique versus gonioscopy. What we see in gonioscopy is actual image rather than expensive technology. So newer technology are expensive one, can't do dynamic assessments and missing core information like Synechies, unable to tell it is primary or secondary pathology, missing minute detail like pattern of pigmentation and limited to narrow section scan. Like you can see in the image, if section is right, that blue line, definitely it will be PAS. So here we can conclude that UBM and ASOCT provide real-time cross-sectional image accuracy, but accuracy and reproducibility yet to be proved. We can document easily, but gonioscopies continue to be crucial, essential for evaluation and management. Thank you. First preference gonioscopy, then ASOCT.
So I think almost always the gonioscopy is the most crucial thing that a glaucoma specialist or any person treating glaucoma should master. And most of the things I think we can detect by skill and experience. Only in situations like you have already mentioned, confirm malignant glaucoma, ciliary body cyst, ciliary body tumor, then probably we can take help of the UBM. Otherwise, regular gonioscopy will detect most of the conditions for glaucoma.
Thank you. That means the gonioscopy is part and parcel of our examination. It is nothing different. So the way we are doing an applanation slit lamp, we should do gonioscopy in our all glaucoma cases. Thank you so much. Now with this, we move on to third presentation by Dr. Srishti Raj. He will be presenting role of shunts in glaucoma management, ab interno and ab externo.
My thanks to the organizers for providing me the opportunity to present my talk here. So it's a long topic, so I'll be discussing a broad view of the ab interno as well as ab externo devices. So there's no conflict of interest to declare. So what is the role of glaucoma drainage devices in current glaucoma management protocol? So we have two type of stents, ab externo and ab interno. Initially it was used for failed trap or for inflammatory glaucomas, but now more and more even primary surgeries can be done with stents as well as combined with cataract surgery. So trabeculectomy or tube. We know that trabeculectomy is still the gold standard for lowering the pressure, and prerequisite for this is healthy conjunctiva. And use of shunts is increasing since last 20 years. So when the surgery is indicated, when the risks are outweighed by the potential benefits, when target IOP is not achieved, or there is a progressive glaucoma damage based upon the disc findings and fields. So these are the some of the stents used. Molteno, Krupin, Barbal, EGV, Adi, these are the external stents. And for internal stents, there are different mechanisms like suprachoroidal drainage outflow, Cypras, which is band, eye stent, supra, and eye star. Then subconjunctival bleb forming like Zen and pressure flow. Then trabecular outflow increasing like eye stent, hydrus, GAT, KDB or canaloplasty, and some of the end stage procedure like DLCP or ECP. So glaucoma drainage devices indications are basically the failed trabeculectomy, inflammatory glaucomas, or if there is any significant barrier to the use of medications regularly, or if it is inconvenient to the patient due to physical impairment or psychosocial issues, or if there is a rapid progression despite the best medical management. Why shunt? What is the problem with trap? So there are a lot of early and late post-operative complications associated with trap, like infections or choroidals or shallow AC and complications of shallow AC. So indications of drainage devices, there are wide range of indications like failed trap, aphakia, pseudophakia, PAS, then post-trauma scar, post-PPV or uveitic glaucoma or neovascular glaucoma. So when to do shunt surgery, there should be appropriate decision to operate. Pre-operative consideration is very important, especially for inflammatory glaucoma like uveitis, where you have to put the patient on anti-inflammatory therapy 1 to 3 days prior to the surgery to get the better result. And per-operative consideration like minimal handling of the UVR iris tissue and friable conjunctiva and sclera. So minimal use of tooth forceps. Also the post-operatively, the follow-up is vital, especially the inflammatory glaucoma. So the aggressive anti-inflammatory therapy is required. So GDD can be valve or non-valve. These are two types of GDD available, and material-wise, mostly these are silicone or polypropylene based. Ab externo, which we are using are mostly AGV or the here. Two others are available. So ab interno available are express shunt, Zen, eye stents, Omni, pressure flow, hydrus. Most of these are not used here. These are some of the designs of these devices. So success rate of drainage devices varies from 70 to 79%, and maximum is seen with Moltena DP device. Complications. Hypertensive phase is usually seen with the valve devices. With AGB, it is seen almost in 40 to 80% of the patient. And use of MMC with shunt is usually not indicated. There is increased chances of hypertonia, flat AC, and choroidal fusions with use of MMC. And complications like persistent hypertonia, vitreous hemorrhage, choroidal detachment, shallow AC, bleb encapsulation. Other complications, though transient hypertonia is seen in 12 to 26% of the cases, but usually it is transient. And diplopia is more seen with barbell type of devices up to the tune of 9%. This was a Fuchs heterochromic cyclitis patient who underwent cataract with glaucoma surgery, who was on maximum medication, and post-operatively he had a good control with one drug. This was the post-PPV patient, PPV patient with 34 pressure on maximum treatment, and after GDD came to 14 with one drug, and vision was also well maintained. This was the infantile glaucoma patient who already had OPK with high pressures on maximum treatment. After AGV, the pressure was 14 with one drug. Most of these GDD devices will require one or two drugs in post-op period. So AGV or ADI. So this was a study published by our group where we compared the ADI versus AGV, and the inference was that both are equally effective, though less medications are required with ADI. This study was the long-term outcome of AGV implantation in post-PPV eyes, and the conclusion was that IOP is well controlled with AGV in these cases also, but trauma-related pathologies were a major contributor to the indications for PPV in this group, and had more chances of failure following AGV implantation. This was our retrospective studies comparing ADI versus AGV, and outcome was the both are equally effective, but considering the cost factor, ADI was well placed. This TVT study shows that equal pressure lowering effect on short-term basis, and 5-year result shows that 49% failure with trab and 30% with tube. And 5-year result shows that early complications were more with tube, and late complications were almost equal. And late complications like resurgery and cataract section were similar in both the cases. This Cochrane analysis shows that there is insufficient evidence show that whether trab is better or the drainage devices are better. So TM based mixed procedures which we usually perform are trabectomy, GAT, KDB, bang. Eye stents are usually costly, so usually not done here. Recently we have done bang in some patient standalone also, and in combination with cataract surgery also, and usually we get the lowering of the pressure around 20%, and also there is a decrease in number of drugs. This is so in conclusion, GDD success rate is similar to GFS, but indicated in failed trab or inflammatory conditions where there is a lot of conjunctival scarring. Preoperative consideration, especially in inflammatory glaucomas, should be considered, and careful patient selection, preferred valve GD devices in one eye patient, and ab interno procedure mostly preferred in mild and moderate glaucoma. Thank you.
Thank you, Dr. Shirish Raj. Any comments from panelists?
I think, as Sir has mentioned, as of now, the current standard approach for most of the glaucoma surgeons is to do trabeculectomy in cases, uncomplicated cases, and reserve the valves, either ADI or the AGV, for patients for glaucoma cases which have a slightly lesser response. For example, the uveitic glaucoma, the neovascular glaucoma, or failed trabs. And the MIGS procedures are coming up in a big way. So patients who have early to moderate glaucoma, where we want to delay the trab for a few months or few years, then we can think of the ab internal procedures like GAT or other eye stents or bang, those sort of implants.
Also, the number of drugs will come down, and
Yes.
that is equally
The ocular surface will be better. Yes, the long-term success of trab will be better.
Thank you.
Thank you. Thank you so much, sir. Now we move on to fourth talk by Dr. Pooja, and she will be presenting on surgical management of coexisting cataract and glaucoma.
Okay, good morning, everyone. So I'll be talking on the surgical management of cataract and coexisting glaucoma. We all know that cataract is the commonest cause of blindness, and also glaucoma is the second leading cause of blindness. With aging population, the incidence of coexisting cataract and glaucoma are on rise, and we are seeing more and more patients with existing cataract and glaucoma. We know that trabeculectomy does well with glaucoma surgeries. Cataract does well. We have excellent results with phacoemulsification. Combining phaco with trabeculectomy becomes an obvious surgical choice for coexisting cataract with glaucoma. Some people prefer doing just phacoemulsification for existing glaucoma and add topical anti-glaucoma medications, but this condition slightly is difficult for Indian scenario, because with elderly population the compliance with medications becomes slightly poor. It is difficult for the patient to continue putting topical anti-glaucoma medication after phacoemulsification. So we see that patient loses interest in topical anti-glaucoma, he loses for follow-up and ends up with being blind. So that's the reason why we should be planning and combine trabeculectomy with cataract surgery. What are the surgical options for this condition? We can do just cataract alone if there is early glaucoma and the medication pressures are controlled with just one topical anti-glaucoma medication and there are hardly any disc changes and field changes. We need to do cataract with trabeculectomy when there is advanced glaucomatous damage and the IOP is uncontrolled with medications. And more recently, we are able to add the mixed procedures, that is microincisional glaucoma surgeries, to cataract in patients who are mild to moderate glaucoma and they are open angle. So when do we plan just cataract extraction alone? Cataract extraction alone can be planned in phacolytic, phacomorphic, and phacoanaphylactic glaucoma, where you can just do plain cataract surgery. If you want to do SICS, you can use superotemporal area for SICS and leave the superonasal quadrant for future trap if required. You can, in mild angle closure glaucoma, where there is hardly any disc and field changes, you can straight away go and do cataract. So there are some talks regarding early lens extraction, or there are consideration regarding early lens extraction. You should consider this with caution. It should be done when the anterior chamber depth is less than 2 millimeters, lens thickness is more than 5 millimeters, and there is a high lens vault of more than 1 millimeter. So for that, you may need an UBM to be done, or anterior segment OCT to judge whether there is high lens vaulting. This causes IOP reduction in 4 to 8 millimeters. The IOP reduction with just phacoemulsification is approximately 4 to 8 millimeters, but it is short-lived. And there are studies which say that the rise in IOP is noticed after 2 or 3 years following the surgery. So coming back to the original topic, that is combined surgery, the visually significant cataract, uncontrolled IOP on single medication is the indication for phacotrabeculectomy. Also, the patients who are non-compliant on topical anti-glaucoma medications or have difficulty in instilling the topical anti-glaucoma medication. Phacoemulsification with trabeculectomy doesn't come without complications. Basically, these are always quite difficult surgeries. Why? Because most of the glaucoma patients are having non-dilating pupil because of chronic use of miotic or pseudoexfoliation. They are associated with weak zonules because of PXF or trauma. The poor endothelium count, high fluctuations in IOP is associated, very well correlated with the poor endothelial count. They are associated with shallow AC, and there are high chances of existing pus, especially in post uveitic cases. So when you are planning a phacotrabeculectomy or combined surgery, be ready with all these gadgets. Like you need to have an iris hook, lens hook, CTR, Sionis ring, high cohesive viscoelastic, dispersive and cohesive viscoelastics. So we need to take good care before and being prepared for a surgery. So typically phacotrabeculectomy will involve Okay, so I'm going to show you a short video of phacotrabeculectomy. I do a two-port phacotrabeculectomy, a superior incision for trabeculectomy and temporal clear corneal phaco. A conjunctival peritomy is very important, vital to not damage the conjunctiva while doing the dissection. Scleral flap, I prefer doing a rectangular scleral flap. Try to make it as uniform as possible. It should not be very thin or not be very thick. A thick flap is associated with early failure, and thin flap with overfiltering blebs. Incomplete side extensions are done. Incomplete side extensions enhances posterior drainage of the aqueous. Mitomycin needs to be applied over a larger area so that there is a diffuse posterior elevated bleb. More posterior the bleb, better it is. A thorough wash of mitomycin C, and then phaco is followed through a temporal tunnel. Temporal entry to side ports, standard phacoemulsification within the bag IOL implantation is very critical. Now go back to your trabeculectomy site, make the entry, do a proper Kelly's punch is used to do trabeculectomy. Peripheral iodectomy is done, and then the scleral flap is sutured. You can suture the scleral flap using 10-0 nylon suture. It can be an interrupted suture and releasable suture. Releasable suture gives us an advantage of placing a tight releasable suture, which you can remove in the immediate post-operative period, depending on the intraocular pressure and the way your bleb is forming. After doing the releasable suture, it's extremely important that we put a proper conjunctival suture. Making a watertight conjunctival suture is equally important. So that is the phacotrabeculectomy. And then more recently, now we are talking of MIGS procedures, or combining our phacoemulsification with GAT surgeries. There are a lot of reports saying that the results are good. It has advantage of lesser post-operative complication, faster recovery. It is as good as doing a phacoemulsification, but there are some chances of having hyphema afterwards. It is preferred to be done in open-angle glaucoma, mild to moderate glaucoma. In pseudoexfoliation and pigmentary glaucoma also, you get good results. So which is the case that you will choose? The above two pictures are the places where you will choose to do a GAT with phacoemulsification. So the angles have to be wide open, and you're supposed to see the Schlemms and all the trabecular meshwork clearly. This has to be done before starting the surgery. So once you're sure, it's just another minute. Just a minute.
You have crossed 1 minute more from allotted time.
So this is, we do complete a standard phacoemulsification, and after completing the standard phacoemulsification, we go ahead with the GAT surgery, where MVA blade is used to make a slit incision in the Schlemms canal or at the area of the trabecular meshwork. A 6-0 proline suture is passed. A humped 6-0 proline suture is passed, and approximately 20 to 30 swipes are taken, pushes are done, and then once you notice the proline suture coming out from the other side, it is pulled, the Schlemms canal is opened, a slit incision in the Schlemms canal is done, and the free end of the suture is grasped with the intraocular forceps. Why I'm not getting? Okay, thank you. So the preliminary results are good with phagotrabeculectomy with GAT. I think we have good results for mild to moderate glaucoma, and everyone should try learning GAT. That's what I want to say. And also phagotrabeculectomy. Thank you.
Thank you, Dr. Pooja, for wonderful videos. A comment from panelist.
I would that specifically angle closure eyes doing care of proper IOP control before planning for surgery, and they should have a give a preocular post block massage is important, and if there is any high pressure fluctuation suspected, then especially plateau iris pre-op injection mannitol also helps.
Yeah. All those preoperative regulations that we need to follow for any trabeculectomy or phagotrabeculectomy are valid for all these surgeries. So if there is high pressure, as a standard protocol, we should start acetazolamide at least 4 to 5 days before the surgery. On the day of surgery, give mannitol, see that the eye is really soft, give a proper peribulbar block, and then go ahead with the surgery. This is a standard protocol that you need to be following for all your phagotrabeculectomies. Yes.
Just to add on to that block part, I think subtenance is becoming a very good choice for glaucoma surgeries, and I'm sure many of us do topical as well. But then, if topical is uncomfortable, subtenance has been an excellent choice.
Definitely, especially for advanced glaucoma, we don't advocate peribulbus. So with this, we move on to our fifth topic, which is macular GCC, role in glaucoma imaging by Dr. Jasleen Dhillon.
So good morning, everyone. We've been using OCT and glaucoma now for over a decade, and I think the role has become quite universal after the initial hitch. And initially, there was a lot of focus on the RNFL, but gradually, we are also now seeing that the GCC is becoming also very important, particularly when we are dealing with early glaucoma. So we all know that structural loss comes before the functional loss, as is seen by many studies. And why should we look at the GCC? Because initial site of injury, is more easily picked up here, since the ganglion cell complex is thickest over here. And so the disease may present elsewhere too as a presenting feature, but the probability here is possibly more. And so macular damage is common, and it may occur early in glaucoma. The structural loss picked up at the GCC more earlier, like I have already said. And secondly, the retest variability is lesser. The variability at the RNFL is more than at the GCC. So the GCC is particularly useful also for detecting progression earlier. It is also relatively unaffected by structural factors at the disc, like the phenotype of the optic disc. It's less affected by the axial length, and so it's more useful in myopic eyes. However, since the RNFL is where you are able to check 100% of nerve fibers, and at the GCC you may miss out peripheral loss, in the arcuate areas. So you would only pick up the parafoveal changes better. And secondly, the macular pathologies, if they are coexisting, they can really affect the result. So if you're checking the GCC, you must also look at the macular scan and see that there is no associated macular pathology. Always a good idea to look at the larger picture, both in the OCT aspect as well as the patient as a whole, see the whole clinical picture. Never look just at the OCT and make your diagnosis or treatment. So, the study by Hood et al. Has shown that macular GCC defects early in course of disease, more frequent, and are very useful in picking up preperimetric glaucoma, which can be missed if you're doing a standard 24-2 visual field test. And the parameters most useful are the inferior GCC, particularly the inferotemporal GCC. And typically these defects look arcuate, they look similar to your visual fields in the corresponding opposite sector. And the parameter to look out for in the very early stages is a global loss volume, which may be below the level. And a very useful sign in established glaucoma particularly is the presence of the temporal raphe sign. And this is said to be very useful in discriminating glaucomatous and non-glaucomatous optic neuropathy. A study done by Perdici et al. Has shown that if you have an abnormal GCC, very often you have a very good correspondence with a cluster field effect. The field GHT might be showing normal or borderline, but if you have a cluster field effect and you have an associated GCC defect, then the possibility of glaucoma is higher. And so this confirmed the ability of GCC to predict early stage glaucoma before the visual field globe indices are altered. So if you have a paracentral, if your GCC macula is affected, you must go for a 10-2 visual field test. There was a study which showed that patients who had normal fields and had an inferotemporal sector arcuate shaped GCC loss, when they were followed up over 6 years, the GCC progression preceded the development of visual field defects in 21.9%, and the visual field progression was seen in 56.9% of patients. So, presence of a GCC thinning is an indication that we should at least be following up the patient more frequently. Also, the focal loss volume, if it is affected at baseline in a preperimetric case, then it is a significant predictor of a subsequent visual field conversion. This was seen in the AIGS group. So GLV is an early sign for glaucoma, and FLV would be useful to detect who are going to likely progress. And of course, look at the pattern of the GCC, look at associated optic disc changes, correlate everything, look for even cluster field effects to get a better predictability, you can say. So yes, GCC helps to pick up early. So you see a patient over 6 years who developed field loss, had not followed up in between, and because the fields were normal, we had not started treatment. Myopic eyes are a subset where the GCC is much better than the RNFL because of the associated issues with the optic disc like peripapillary atrophy and tilted discs. And again, here the inferior GCC and GLB have the best diagnostic performance. OCT in general is useful to give us additional information in poor visual field performers. OCT and VFA taken together, of course, give us the best idea of risk assessment. However, the OCT has higher sensitivity, detects within shorter period of time, and the GCC trend analysis was more useful than the RNFL trend analysis in this study. However, there are individual variations, so you have to keep in mind that. And if you're looking at imaging, you have to be very careful of the associated confounding factors, the fact that it can have a lot of false positives or negatives. And of course, look at the effect of aging, look at the effect of cataract. If you've done a cataract, you need to redo the baselines. So yes, it's giving us a key information. We've been generally doing the RNFL GCC scan OptoView along with the visual fields, and we are seeing that there is association of the GCC findings with subsequent field conversions. So thank you very much.
I think it's a very useful adjunct to the detection of early glaucoma, and as she has rightly mentioned, in some cases like glaucoma with myopia, and there will be some cases where there will be some visual field defect. The OCT RNFL may come out to be normal, but there is a corresponding defect in the GCC in the macular region. So I think it's a very useful adjunct, particularly when the same machine can do these tests. There is no reason we should avoid this.
Evolution of glaucoma surgeries, trabeculectomy and beyond by Dr. K. Subhashini.
Good morning, everyone. So the topic of my presentation is evolution of glaucoma surgeries, TRAB and beyond. So for more than half a century ago, there has been a multitude of surgeries for uncontrolled glaucoma, but all of these were wrought with complications, the earliest being iridectomy, then the trifine operations you would have heard of, cyclodialysis with intraocular drainage, iridine lysis, then we have the Aioc corneoscleral trifining. So all these are obsolete now. In 1968, Sir John Kearns, he developed the trabeculectomy technique. So it was based on the concept that the trab meshwork and the inner wall of the Schlemm's canal offer the maximum resistance to the aqueous outflow. And even before Kearns, it was Sugar who actually tried experimental trab on eye bank eyes, and in fact, he was the one who coined the term trabeculectomy. So Kearns' trabeculectomy he created, in this technique, he created a flap starting in the cornea 2 to 3 millimeter anterior to the limbus, and it was hinged on the sclera, and a deep scleral lamella containing the Schlemm's canal and the trab meshwork was excised, and then the flap was sutured. In 1975, Watson and Barnett, they modified Kearns' trabeculectomy, and this was called the sclerokeratectomy in Watson's technique. 5 by 5 mm scleral flap was hinged anteriorly, and a second full thickness corneoscleral flap containing the scleral spur and the trab meshwork was excised under the superficial flap. So currently, this is the technique that all of us follow, the sclerokeratectomy. And because of the main cause of failure of TRAB was the subconjunctival fibrosis, then there were techniques to modify and modulate the wound healing process. In that 5FU was the first to be used, but mitomycin became more popular. for obvious reasons. Then beta radiation also was tried, corticosteroids, anti-VEGFs, amniotic membrane, ologen, and even modification of the suturing technique, use of releasable sutures and adjustable sutures and suture lysis. So, Dr. Peng T. Kaur, from Moofield's, he introduced the Moofield's safe surgery system, also called the enhanced trabeculectomy, because with the use of mitomycin, there were more complications like bleb leaks and polycystic blebs, dysaesthetic blebs. So, his concept was to have a large treatment area with mitomycin, and here the scleral flap also didn't reach up to the limbus, just 1 millimeter short of the limbus it stopped, and a single scleral punch sclerostomy. So the idea was to have a posteriorly directed flow. So this is the technique that most of us follow. So however, TRAB has its complications, early complications like leakage, hypotony, and late complications like leakage and infections. So in 1989, so because of these complications of TRAB, because you enter the chamber, so the chances of leakage and hypotony happens. In the 1990s, deep sclerectomy, Fyodorov introduced this deep sclerectomy technique, popularly known as the non-penetrating deep sclerectomy. And in 1999, Stegman introduced viscocanelostomy. So here a deep scleral flap is excised under a superficial flap. So it creates a scleral lake, and the aqueous actually percolates through a trabecular Descemet's window. So this was all to prevent this healing process and to reduce the complications which was seen with trabeculectomy. But however, the intraocular pressure control was not as good as for a TRAB. Then canaloplasty also became popular for some time. So this is an extension of the viscocanelostomy procedure with the addition of a tenoproline suture, which was passed circumferentially 360 degree through the Schlemm's canal and tied with enough tension. This is to stretch the TRAB meshwork. Then the glaucoma drainage devices were being used. In fact, in the 1900s itself, so many techniques were tried where the horsehair, so in 1906 horsehair was tried, then suture materials. All these were to have a conduit between the antechamber and to the subconjunctival space. However, the first commercially available implant was the Molteno implant. And as you all know, the aqueous shunts could be valved or non-valved, and they vary in material size, shape, size. And the popular ones are Ahmed, Bawel, and the prototype of Bawel, the Indian indigenous device, the RD, which is very popular. And there are also Paul glaucoma implants, and then recently the non-valved part of the Ahmed, that is the Ahmed clear path, has also come up. And tube surgeries also do have their complications. Early ones are hypotony, shallow chamber, and late complications, again, hypotony, especially with the non-valved, and then motility disturbance and infection. So the surgical armamentarium for glaucoma includes the traditional trabeculectomy and the GDDs, then even the laser procedures, and the newer ones, the MIGS. So what is MIGS? It's the minimally invasive glaucoma surgery. This came up to reduce the complications. That is, they are supposed to have a high safety profile and with a shorter surgical time and a shorter recovery time. So broadly, based on which part is targeted, they can be divided into under trabecular outflow. We have the iStent, Hydrus, trabectome, GAT, BANG, and Kahoot blade. These procedures also come under this trabecular outflow group. Then for suprachoroidal, we have the iStent Supra and others. And in subconjunctival ab interno technique is a Zen, and ab externo the pressor flow. Uh, yeah, and then there are also future MIGS devices, and then even this iWatch implant, which can be attached to any drainage device, and you can titrate the pressure. Uh, so if you compare all the glaucoma surgical procedures, trabeculectomy stands above, supersedes the others with a high intraocular pressure control of 50% at 5 years compared to the other procedures. So in summary, what I would like to say is the newer procedures are still evolving and are yet to replace TRAB as a gold standard for preservation of visual function in early and moderate glaucoma. But TRAB still remains the time-tested surgery for advanced glaucoma. Thank you.
Thank you, Dr. Subhashini. A wonderful presentation and a very good compilation of all the surgeries, but then trabeculectomy remains the gold standard. With this, we move on to another presentation by Adrian Briganza. That is the conversion of topical trabeculectomy, phacotrabeculectomy, step-by-step approach.
I would just like to add that the pediatric glaucoma surgeries have evolved over the years. Like goniotomy was first described by Barkan, then came trabeculotomy, then combined trabeculotomy with trabeculectomy, and now we have a 360-degree illuminated microcatheter assisted trabeculotomy.
Yes. Even the trabeculectomy has become a better because of the evolution of the mitomycin C and 5-fluorouracil. So we are getting good results even for our repeat traps, the where we are like thinking of using a valves. So always there is a debate whether to use tubes or to do trap with mitomycin C or any other associated things.
Good morning. Can I start? Yeah. I'm Dr. Adrian Braganza. At the outset, and this is my topic, it has to do with topical trabeculectomy associated with SICS and phaco. Can I have a show of hands of people who do this routinely? One. That's it? Okay. Yeah, okay. Either. Okay, I'll just start now. So this was my initial hesitation, but over the years I've overcome that, and I would like to share my experiences in the 6 minutes that I have. Okay. Yeah. So this is the content. The introduction. The authors Azzurro and Blanco and Vicari about 15 years ago published their papers comparing peribulbar with topical trabeculectomy, and found that there was absolutely a minimally different features between both of them. The need for topical anesthesia in phacotrabeculectomy or TRAP is to avoid the risks associated with peribulbar anesthesia, which is globe perforation, retrobulbar hemorrhage, etc., etc. In advanced glaucoma, topical anesthesia does not increase orbital pressure and avoids further optic nerve damage. Previous studies have shown that topical anesthesia is a safe and effective anesthetic method in trabeculectomy or phacotrabeculectomy. Patient selection, very important. A POAG patient with coexisting visually significant cataract who are cooperative and with the ability to fixate light, most important. Avoid patients with secondary and angle closure glaucoma, one-night patients, mental instability, and language barrier problem. Counseling, very important. The risk versus benefit evaluation has to be done by the surgeon himself. Clinical picture versus the surgeon's competence vis-a-vis a time factor, also very important. My standard is a soaked pledget with 4% xylocate. I do use a 4 suture for the superior rectus and intracameral lignocaine. This is the chair time, also very important, and is your single most important tool to determine procedure eligibility. My anesthetic of choice, the 4% lignocaine. This is, I put the pledget there for about 2 or 3 minutes. As you can see, the patient's eyes are moving all over the place. That's when I start the counseling and gently reassure the patient, followed by a superior rectus suture. As you can see, there's no pain at all. This is a topical phacoemulsification with trabeculectomy. After the anesthesia is done, SR suture is put in. A trap flap is made. A cautery is done with a gentle irrigation of 4%. My preferred flap is the triangular flap. Then move on to the temporal side and perform the phaco, routine phaco, nothing spectacular. It just has to be done a little quick. Then move back to the top. If I find this the conjunctiva is fine, I don't use MMC routinely. My trap punches are with the Kelly 2 punches wide. I sometimes put 3 sutures, 1 tight and 2 not so tight, or just a single tight one. It all depends on the clinical picture then. As you can see, it's pretty routine, and it's something that all of you all follow. Nothing spectacular. Mine is a phonics-based approach, so the atovicral has to be a little tight. I get a good bleb because I don't put a patch on top. So this was a study by Aioc, one of the leading lights in glaucoma, a few years ago, where it was a randomized prospective study combining topical versus retrobulbar anesthesia in combined phacotrabeculectomy. He used a pain score analog with which 0 to 2 would be on the minimal pain score levels. As you can see, the graph is almost nil. The patients graded their experience based on their perception of tissue manipulation, touch, sensation, and microscope light, and during the surgery. This is vis-a-vis the surgeon's skills too. His results for the pain control was as efficacious as retrobulbar anesthesia, and both provided optimal operative conditions. Topical anesthesia is safer than retro anesthesia for combined phacotrap, as it eliminates many of the potential problems. This was his method, pretty similar to mine. This is one in which I've done a topical SICS along with trap. After the anesthesia, I did a temporal stab incision SICS.
Sir, request you to sum up, please.
Yeah, it's over. That's it. And yeah. Sorry. So, in conclusion, these are the advantages over subtenons. and patching is not required because there is less resistance to drainage. The advantages are the patient can respond more accurately, no use of anesthetics, and involuntary movement is minimized during the operation. There are disadvantages: a little pain during cautery, the need for supplemental anesthesia sometimes, and extraocular movements. So what is holding you back? It's a pretty good technique. Thank you.
Thank you so much.
Very good video, Dr. Burganza.
Thank you.
One thing, instead of using superior actus anchor suture, could you have used you have tried the conjunctival anchor, corneal anchor also?
I routinely do not use the corneal thing. In 2 of my cases, they cut through, and the patient had a little discomfort. You need to go more than 2/3 the distance of the cornea.
Other thing is, for trap, we are using a long blade wire speculum which rotates the globe inferiorly, and usually I am not using any anchor suture.
Okay.
And except in some cases where the globe is tight or it is not rotating inferiorly. So 80 or 90% of cases we are doing without anchor sutures.
No,
could
I
you
do.
try that?
That gives me an advantage. Now I have less movement when I have an anchor suture. So, and it's painless, so you might as well use it if you have the.
Sir, I have one question. How is your experience with the angle closure eyes with topical?
No, I absolutely don't do angle closure eyes. I put that in the indications.
Okay.
It's only primary open angle glaucoma.
Thank you, sir. Thank you so much. Now we move on to medical management and pediatric and pregnancy management by Dr. Basu. We are running short of time, so I request please sum up early.
Thank you, ma'am. After that exciting videos and all, this is again a theoretical topic. So I'll be talking on medical management in pregnant and pediatric patients.
Slides, please.
So first I will talk about the pregnancy and lactation. Before delving into the topic, this classification is actually required, the FDA classification from category A to category X. The category A is safety established in human studies, the drugs who are safe in human studies. Category B is those which shows safety in animal models, but there is no human studies. Brimonidine is a drop in category B, and category C is uncertain safety in human studies and animal studies showing definite adverse effect. So maximum drops are in category C, beta blockers, CAI, PG analogs, and miotics. Category D is unsafe, and evidence of it is there is in certain clinical circumstances. And category X is definitely unsafe. So we are lucky that we don't have any anti-glaucoma medications in category D and category X. So most drops are in category C and brimonidine is in category B. I'll discuss each and every drops drugs. The beta blockers can cross the placental barrier and it can risk in fetal bradycardia and cardiac arrhythmia. So we are very skeptical about using beta blockers, but obstetrician are randomly giving oral beta blockers for hypertension in pregnancy. Alpha 2 agonists are most safest drops, but it can cause CNS depression and apnea when transferred through the placenta, or in newborn through breast milk. So it should be discontinued just before the labor. Carbonic anhydrase inhibitors we should monitor acidotic status carefully. There is a study shows malformation of the vertebral bodies in rabbit, but no human data are available. There is one study by Osha et al. Have shown that it's a case report actually. Neonatal sacrococcygeal teratoma is seen with the oral acidazolamide use. But again, in the contrary, another study done by Hahnemann have shown that there is no major fetal anomaly or minor anomaly in 1024 pregnant patients when they are given oral CAIs. So in the later stage of pregnancy, if we are using oral acetocolamides, we have to be cautious about neonatal electrolyte imbalance. Prostaglandin analogs have shown a highest incidence of miscarriage in animal studies, but it is debatable actually how much percentage of drug is going into the system. Meiotics can cause cholinergic side effects like neonatal hyperthermia, restlessness, seizure, diaphoresis, and it can cause it can show mimic the signs of meningitis in pregnant women. Oral hyperosmotics, no animal studies are yet reported, and human trials are not done, so there is a questionable risk. Newer drugs like ROCK inhibitors or latanoprostol budot have shown theoretical risk of stalled labor and should be avoided in the peripartum period if possible. So ideal management would be first line of treatment should be brimonidine in first trimester and second trimester, should be discontinued in the third trimester just before labor, and from second trimester onwards we can give timolol and carbonic anhydrase inhibitor. PG analogs should be given with caution, obviously, has shown to induce labor in animal models. And if we are not sure of using medical treatments, we can offer SLTs or laser trabeculoplasty also. And if we are using these drugs, these things should be monitored. In beta blockers, the fetal heart rate should be monitored. Bradycardia can happen. Alpha agonist we have to see the fetal growth monitoring. PG analogs, we have to watch for premature labor. And oral or topical CI, we have to monitor the growth of the fetus. In lactation, there are two drugs which definitely definitely transfer through human breast milk is brimonidine and beta alpha 2 agonist and beta blockers, and others are unknown. Brimonidine should alpha 2 agonist should not be used in lactating mothers because it can cause sinus depression in the neonates. CAIs can be used with punctal occlusion. Coming to the pediatric patients, there are two major group of glaucomas, the primary glaucomas and the secondary glaucomas. The main treatment of primary glaucomas is surgical, so we have to just give the medicines for buying some time, but the main treatment is surgical, so we are not worried about that thing. But for secondary glaucoma, there is a group of secondary glaucoma which can happen in pediatric age group, and main treatment is medical. So in pediatric group, beta blockers are widely used, but it should be avoided in premature babies, or if the baby has some restrictive airway disease or asthma or some known cardiac disease. In those cases, it should be avoided. Alpha 2 agonist is strictly contraindicated. It causes CNS depression and apnea. There are case reports that the baby has gone to coma in 30 to 60 minutes of use of alpha 2 agonist. Carbonic anhydrase inhibitors are widely used. It has good tolerability, but it is contraindicated in post-PK patients. And oral CAIs in children have side effects like it can cause respiratory alkalosis or tachypnea. And PG analogs are relatively safe, but asthma exacerbation can be there with increased inflammatory mediator. And there can be PAP changes like periorbital atrophic periorbitopathy can happen. In aphakic glaucomas, meiotics can be given, but the cholinergic side effects we have to always remember: the diarrhea, GI cramping, hypotension, headache, salivation, syncope. All these things you have to remember. So fixed dose combination is always preferable if required, because there is less preservative and lesser side effect, and CAI and beta blocker combinations are first choice, and we can use PG analogs also. Thank you so much.
Thank you, Dr. Basu, for wonderful compilation of the drugs used in pregnancy, lactation, and pediatric group, which are very important. But in all the cases, we should advocate how to use the punctal block. Thank you so much. With this, we move on to our last presentation, which is Pearls and Pitfalls in Interpretation of OCT and Diagnosis of Glaucoma by Dr. Sanjay Dutt Daulat Thakur. Spelling it there.
Good morning, everyone. My previous speaker, Dr. Jasleen, was talking about the confounding factors in OCT. So that is basically my topic, pearls and pitfalls in interpretation of OCT. We have to remember that basically there are 4 different manufacturers of the spectral domain OCT, and we study 3 different parameters for glaucoma. The most important thing to remember is that each machine has different scan patterns, software segmentation algorithms, and display outputs. So we cannot compare the data of one machine with another. First of all, we must check the patient's name and age to identify, and then all data is compared with age match normative database and color coded accordingly. Next, we must check the signal strength. Each manufacturer has minimal acceptable quality. For Cirrus, it is more than 6. For Spectral, it is more than 15. So we should remember that lower signal strengths will give lower RNFL thickness, which improves with rescanning. And a drop of lubricant will not only improve the signal strength but also the RNFL values. And it has been reported that there is a 9% increase in average RNFL thickness after cataract surgery. We should also know the color codes properly, just not red and green but white and gray also. The values more than 95% of the range is labeled as white, and the values that are not compared with the normative data are color coded gray. So we usually only stick to red, green and yellow. So in our over enthusiasm for embracing OCT in the diagnosis of early glaucoma, as they say, we sometimes just follow the red and green and diagnose based on OCT only. So each technology has its own limitations. Like these blood vessels may cause shadowing and lower RNFL values. In the past, we used to have this motion artifacts characterized by horizontal displacement of images, but with the newer machines, this is no more a problem. Sometimes a floater comes in the path of the calculation circle and we get lower RNFL values. So if we ask the patient to blink and the floater moves away from the calculation circle, then the values are back to normal. So all these artifacts can be broadly divided into 3 groups: patient dependent like media opacities, operator dependent like signal strength, and device dependent because of the limitations of the normative database. So here is a picture from Heidelberg printout which shows a lot of red areas, and if we see the fundus, we see that this RNFL thinning is due to toxoplasmosis and not due to glaucoma. So it has to be clinically correlated. So this is a retinal disease and not a glaucoma. Another picture from Cirrus printout showing lot of RNFL thinning, and when we see the disc, it is myopia. So in myopia, the superotemporal and the inferotemporal bundles converge temporally. So the height of the hump is normal, but it is displaced laterally. So we get red areas in the normal expected places. So this is due to myopia and not due to glaucoma. This is another picture showing lot of red areas in the RNFL table, but if we see carefully, we see that the disc has not been centered properly. And once the disc is centered properly, all the values come back to in the green range. So this is a centration error by the operator. Another picture from Heidelberg showing a lot of red areas and TSNIT graph dipping into the red sector. And if we see carefully, the RNFL segmentation has not been placed centrally. And once this is placed centrally, all the values turn to green. So this is another centration error by the operator. Another picture showing lot of red areas in the sectoral analysis and even in the TSNIT graph, even dipping to 0, which is not possible because there are some glial cells and blood vessels. So the RNFL values cannot go to 0. But this can occur in tilted disc, posterior staphyloma, and peripapillary atrophy. So this is a segmentation error by the device. Another problem with the devices is a limited number of database. For example, in Cirrus, only 284 healthy individuals are recruited in the normative database, which are in the age range of 18 to 84 years and refractive error range of -12 to 8 diopters. So many results may be flagged abnormal statistically in patients who are not represented in the database. Thus, they do not represent the real disease. And we should be alert about these facts and not overtreat this red disease. The vice versa can also occur. In this printout, you can see only left eye is having glaucoma and the right eye is not glaucomatous. But if we see carefully the disc, the myelinated nerve fibers have increased the RNFL values in the right eye, thus masking glaucoma. So this is an example of green disease where we may miss glaucoma because the OCT does not pick it up. One another limitation of the OCT machines is the floor effect. As I was saying, the RNFL values cannot go below 40 microns because of the presence of the glial tissue in the blood vessels. So in advanced glaucoma, we have to rely on automated perimetry rather than OCT. To summarize, OCT alone should not be used to make the diagnosis. An abnormality in the OCT requires clinical relation, and it is not man versus machine, but man plus machine. Thank you, Chairman Scientific Committee, Dr. Partha Vishwas and his team for allowing me to present this.
Thank you, Dr. Sanjoy. It's a wonderful presentation, and we all know red-green disease. Panelist wants to put any last comment, and after that, we will have a group photograph.
I think Sir has covered all the important points that are practically important. Particularly, the eyes sometimes tend to get dry if the operator does not put a drop of lubricant, and positioning the centration. So those are very important points, and we should take into consideration everything: the clinical appearance of the optic disc, the perimetry, and the OCT, and also the macular GCC before appearing as the final diagnosis. Thank you.